I'd like to welcome Fanshawe alumni, Cristina D'Alessandro, and I work with Cristina in a couple of other venues, but Cristina is currently pursuing a master's degree in health research methodology, and she's a PCP with York Region. She holds a Bachelor of Arts in Women's Studies from the University of Toronto and studied cardiovascular physiology at Dalhousie University. Her research interests include optimising cardiovascular care in the pre-hospital arena, with particular attention to the female population and the role of cardiac point-of-care ultrasound. Her work has spanned both realms of academia and advocacy for women's heart health, and she's going to speak to you today about women's heart health. So please give her a round of applause.
Thank you so much, Alan. It's an absolute honor and privilege to be your closing speaker today. So thank you so much for having me, and also thanks to my dad for being here today. So this is an enormous topic, and I am by no means an expert, and the more I understand, the more I realize that we don't understand. So this presentation is called Misunderstood, and it's intentionally borrowed by the Heart and Stroke 2018 Heart Report. So intentionally to bring awareness to that document. Parts of this presentation were from an older presentation called She Can Go to the Waiting Room, but is revamped and revisited for you today as a fully loaded and hopefully condensed consciousness-raising package. So what if? Take a second and dream with me. What if you were called Code 3 for a generally unwell patient? You arrive on scene to meet, let's say, Mrs. Schaefer. She's a 55-year-old woman. She's a 20-year history of smoking. Her chief complaint is unusual fatigue. She did have a little bit of mid-sternal chest pain prior to arrival, but it's resolved now. No other history to disclose, but she did mention that she doesn't like going to her doctor, and she hasn't seen an EP in many years. So as a good paramedic, as a good Fanshawe paramedic, because you're not only a good clinician, you're also an architect of progress, you always maintain a very high index of suspicion. So you do a 12 lead, and this is what you see. Maybe some subtle SD changes in the anterior and lateral leads, but nothing really too jumping out at you, let's say. So you give the talk that you will give 1 million times in your career. Mrs. Schaefer, all your vital signs are normal. Your ECG is not showing anything acute. It does not look like you're having a heart attack, but we should probably take you to the hospital anyway to get some blood work done. On the way to the hospital, you learn about her family, her deceased cats, her recent recovery from her tooth abscess. But what if you could look under the hood of this situation? What if you could have a mechanical lens, not just an electrical lens, to actually see her heart? She did have chest pain prior to arrival, but since it resolved, you didn't give it a say. So what if you had a handheld cardiac ultrasound device? Some people call it a portable transthoracic echo, which it essentially is, but we like to call it HHCU to not mistake ourselves for cardiologists. And so what if you have your handheld echo? It's only 390 grams. It's made by GE Healthcare's V-Scan, and you have it in your toolkit, and you pull it out, and this is what you see. I think you could press. This is what you see. So what are we looking at? Is this an eyeball? Is this a stomach? Is this a trachea? No, this is the heart, because I'm always talking about hearts. So this is your parasternal short axis view, obtained when you place the probe on the left sternal border at the level of V3 and V4. The index marker is going to be pointing towards the left shoulder, and if you could play it once more. What you're seeing here is anterior wall hypokinesis. So let's bench all of that for now and look at some objectives. So we're getting a glimpse into the discrepancies in research, screening, and diagnosis of heart disease. We're going to gain some general but potent awareness into the sex-based pathophysiology of atherosclerosis, predominantly the differences between coronary artery disease and microcoronary dysfunction. And we'll have a brief overview of 3 acute coronary syndromes that are luckily now recognized as acute coronary syndromes because they weren't previously. Sorry, could you go back? Back one to the objective. And then the last objective is we're going to have a quick peek at POCUS. So a little terminology disclaimer. The term woman here used throughout this presentation does not claim that all women have equal access to the healthcare system, nor does it claim that they're treated equally by healthcare providers. I'm also absolutely not proclaiming that cardiovascular risk factors don't vary greatly between ethnicity, because they absolutely do, especially in the South Asian, Chinese, and Afro-Caribbean populations. And they also vary greatly between socioeconomic status and geographic location. So today we're going to be moving beyond what's called the bikini approach. Where are my two first-year students? I had a little bit of a debrief on this in February when I spoke to them at Heart Health Month, so you guys have a bit of an advantage here. And you're very well prepped for this conversation. So we're moving beyond the bikini approach, which is seeing women's health as the totality of breasts and reproductive organs. So what gets left out of this equation is, in fact, women's hearts and the role that reproductive hormones play in vascular health and homeostasis. We'll be moving today from a critical stenotic framework to cardiovascular care to a more multifactorial approach, which is very complex. So we're going to be shifting paradigms. So everyone is going to be moving from the left side to the right side. We're not going to leave anyone on the left side of the fence today. So these are a couple easy kind of to read pictorials from the Misunderstood report that I'll encourage you to follow up with after this presentation. It was compiled from a 14-minute online survey of 2,000 females conducted by Intentions Consulting between June 23rd and 29th in 2017. There's a total of 2,000 respondents, and these are some of the big sort of key stats that came up, which are things that we sort of always knew but didn't really have the American Heart Association's recognition of. So 2/3 of heart disease clinical research focuses on men, right? So we're behind not only in heart disease for research for women, but all areas of women's health, excuse me. So prior to 1993, women were absolutely excluded from all clinical trials in the United States, and prior to 1998, it was the exact same in Canada. Early heart attack signs are also missed. Sorry, quick one. Early heart attack signs are also missed in 78% of women. I'm going to read that again. Early heart attack signs are missed in 78% of women. So those women could be your sister, your best friend, your 5th grade teacher, or your mother, as it was in my case. So it's a little playback actually to me and my mom at Fanshawe graduation. She's luckily still alive and well today. My mother actually had a very classical male pattern heart attack, which we all know very well, so I won't go over it. And luckily she survived without any intervention or hospitalization. The only footprint was a pathological Q wave on her ECG that appeared a couple years later. But every day I do live in fear that her cardiovascular care is mismanaged, and hopefully after the end of this presentation you'll understand why. So factor myth, quick little game, no stress here, I'm going to give you all the answers. So factor myth number 1, most women die of cancer. What do you think? We hear a lot about breast cancer, so there must be more women dying of breast cancer. Right. So myth. 5 times as many women die of heart disease than breast cancer. The reason why that's not well understood is because heart disease doesn't have a strong enough PR campaign. So heart disease kills more women than all cancers combined. Number 2, heart disease is a man's problem. Factor myth. So it's, again, a myth. More women have been dying of heart disease than men since the early 1980s. 1 woman every 20 minutes in Canada will die of heart disease. So in an 8-hour day, like today, there's approximately 24 women that will die. It's the leading cause of premature death in Canada. And in the United States, because they have better, more robust databases than we have, we're just starting to begin to formulate ours. But it's been estimated that 60,000 more women die of heart disease than men each year. Number 3. Is another myth again. So women and men with heart disease get the same care. A 2016 New England Journal of Medicine study found that female heart patients under the age of 55 were 7 times more likely to be misdiagnosed by ER physicians than that of men of the same age. So they're misdiagnosed for having acid reflux, anxiety, depression, symptoms of menopause. fibromyalgia, or even just the common flu, essentially. But even when they are correctly recognized, because their clinical presentations are similar to men's, they're still undertreated and underdiagnosed. So they're less likely than men to be placed on beta blockers, statins, ACE inhibitors, all that we know are very crucial for the prevention of future cardiac complications, or to receive implanted defibrillators, or even aspirin for chest pain, like Mrs. Schaefer at the beginning of our presentation. The last point here is actually a fact. 60% of women who die of sudden cardiac death have no prior history of heart disease. So this is shocking, saddening, maddening fact. And the rate of sudden cardiac death of women in their 30s and 40s is actually increasing much faster than it is in men in the same cohort, rising 30% in the last decade. And part of this reason is potentially due to spontaneous coronary artery dissection, which we'll learn about, which has been reported in women as young as 17. So don't think that heart disease is an old woman's disease or a man disease for that reason. Okay, so we're going to be looking at the Women's Ischemia Syndrome evaluation. So this is Dr. Noelle Berry-Mertz. She's my absolute favorite cardiologist. Her work has shaped the trajectory of my whole life's career. And it took me 4 years to get the courage to just write her secretary an email. And yesterday I had the opportunity to meet her at the Ottawa Women's Heart Summit and actually have lunch with her and have a one-on-one peer mentoring session with her. So it was phenomenal, and conferences are expensive, but don't stop investing in them because they have big benefits. So on to whys. So the Women's Ischemia Syndrome evaluation, raise your hand if you've heard of it. That's common. Okay, so it began in 1996, 22 years ago. It's a division of the National Institute of Health. It's a branch of the Heart and Lung Foundation. The WHYS, as I mentioned, is a landmark investigation. Dr. Noelle Berry-Mertz is out of the Cedars-Sinai Medical Center in Los Angeles, though there are 6 or 7 other sites and universities that collaborate with her, and she's really laying the groundwork for better ways to evaluate and treat women with heart disease. So it was the first major heart study to include women. Over the course of about the first 10 years, there was 25,000 participants, and it was designed principally to answer 3 questions. How does ischemic heart disease develop in women without arterial blockages? And there are multiple causes. Would some other cardiac imaging method provide better clues to ischemic heart disease in women? And what role does estrogen and other female hormones play? So today we'll be looking at these 3 studies here, and they'll be just very general key highlights from them. They're all published in the American Journal of Cardiology. The first one is published in 1999, and the bottom 2 are companion documents published in 2006. Let's talk about estrogen. So estrogen comprises a very diverse family. It plays a large role in vascular health and endothelial regulation. One of the largest reasons why women have a buildup of plaque in the microvasculature and their symptoms are so diffuse instead of the macrovasculature is due to estrogen. So what are the estrogens? I have a list here. So we have estradiol at the top. Estradiol is predominant in the pre-menopausal years, and it's later converted through peripheral conversions of androgen in the adipose tissue in the postmenopausal years to estrone. And estriol, I'm probably pronouncing that wrong, is a metabolic byproduct of estradiol. So what's really important to remember from these slides is not the names of the different types of estrogens, but that there are different types of estrogens, that there's a predominance from one to the others and it shifts through a woman's lifespan, but also that women's blood vessels are exposed to extremely high changing levels of estrogen throughout our lives. First during regular menstruation, then pregnancy, potentially preeclampsia that has a whole other load of problems, gestational diabetes, and then before and after menopause. So these estrogen affects how blood vessels narrow and widen and how they respond to injury. And also, how they respond to injury and how they dictate change in the behavior of our vessels. The estrogen level in menopause is 1/10 what it was in premenopausal decades, so it changes very drastically. Awesome. Okay, so more on the WHY study. This is probably one of my favorite slides because it most simply describes the differences between male and female atherosclerotic phenotypes. So at the top we have the male pattern fatty plaque that has been nicknamed by Dr. Mertz as the beer belly plaque because it protrudes and it's uneven. So you have to remember that just as men and women put on weight differently in their bodies, the same thing happens with plaque in the heart. It looks different. So we have the beer belly, the top, which is the more male pattern, and then we have the female pattern at the bottom that is, as Dr. Noel Mertz says, packed down nice and tidy. It's more even, and it's described to be more like cellulite. So what happens in the male pattern, sort of a beer belly plaque, is that it protrudes into the lumen of the artery. We know this type of pathogenesis well, right? So it protrudes into the lumen, and then you have an explosion. You have an explosion. Men explode, and this is a coronary thrombus because of a break in a fibrous cap, and it shows a protrusion into the vessel lumen. Whereas women erode. This is the coronary thrombus because of endothelial erosion, which causes constriction of the blood flow due to the narrowing of the artery. So this graph is a little bit older, and it's done on purpose because I want you to understand that women's heart disease, although now thankfully it's gaining a lot more traction in mainstream consciousness, it's not a small and a new problem, it's a big and an old problem. So this graph demonstrates the percentage change in coronary heart disease mortality in black and white women as compared with white men. It's always very important to take not only sex into account, but also race as well, and it's a very under-researched area, so that's why I also included this graph, is because I like the difference of the multiracial analysis. So as you can see here, this is between 1979 and 1998. We have a decline in mortality rates, is the bottom black line, for men. So it turns out that a system that's actually made to reduce heart disease in men, for men, by men, works really well in men, but not so much in women. Sorry, this goes ahead too quickly. So in women, you have the line here, the white females, their mortality rates aren't declining as much as this line, and then you see even less of a decline with African American women. So I apologize, it's a little bit blurry. I took it yesterday at Dr. Mertz's closing speech. So apologies that it's a little bit blurry, but I really wanted it because there's very few graphs that we have, and absolutely none that we have yet in Canada, that depict mortality rates of cardiovascular disease in men and women. They usually just lump them together, or when they do, they don't make enough sort of more detailed analyses. So this is the cardiovascular disease mortality rate from 2000 to 2013, and this is in the United States from the WISE study. So you'll see a decline. However, this is not in any way, so there's actually a 43% reduction here from 1997 to 2007, which is phenomenal, but we're not actually seeing the same reduction in Canada. So let's talk about a few of the acute coronary syndromes. So cardiac syndrome X is the most historical one. It's exertional chest pain, exertional angina, positive stress test, and a negative angiogram. So this chest pain occurs in the absence of macrocoronary blockages. It can present as STEMI, it can present as non-STEMI. There's a lot of differences in expert opinion. And then we have microcoronary dysfunction, which is also a form of cardiac syndrome X. So this is heart disease that affects, again, the tiny microvasculature in the subendocardial level, right? So there's a lot of epicardial, very epicardial heavy in our training, but let's talk about the microcoronary dysfunction and the microcoronary beds and the subendocardial level. So MCD occurs when there's damage to the inner walls of the arteries, like that very diffuse cellulitis kind of builds up a plaque, which causes a very poor constriction and dilation of endothelial dysfunction. So the symptoms can be very diffuse, and it can occur in both the presence and the absence of chest pain. So here we have the macrocoronary arteries, and the small one zoomed in this picture to the top right there are the microcoronary arteries, because they exist. And this also explains well, as I mentioned before, why not as many women have the typical classic mid-sternal crushing chest pain with radiation to the left jaw, your diaphoresis, your pallor. Sorry, this is an on and automatic thing, keeps jumping, sorry about that. So let's talk about the endothelium now. So what is the endothelium? Does anybody know? So the endothelium is a monolayer of cells covering the vascular lumen. For years it was thought to be a mere physical barrier between circulating blood and underlying tissue. But we now know that endothelial cells are metabolically active with very important paracrine, endocrine, and autocrine functions that are all absolutely indispensable for maintenance of vascular homeostasis. This is the chest pain that comes and goes. This is the chest pain that's non-specific. This is the chest pain that's hard to quantify. This is the chest pain that resolves prior to your arrival or comes back or only comes back a little bit. This is endothelium. This is endothelial dysfunction. This is microcoronary dysfunction. So what is spontaneous coronary artery dissection? It's probably the most terrifying. It's nicknamed the Phantom Menace. 80% of SCAD patients are women. As I mentioned, the average age is 42, but the Mayo Clinic reports cases as early as 17. If you Google SCAD, the first thing that will come up will be the Savannah College of Art and Design, so that's not the right SCAD. You have to put in spontaneous coronary artery dissection. So it's found typically in young females without classic coronary risk factors, and it's thought to be a very rare cause of acute coronary syndromes. So the prevalence of SCAD in ACS subjects is still unclear. The presentation is variable between STEMI, non-STEMI, unstable angina, or sudden ventricular arrhythmia. But this basically occurs when the inner and outer layers separate. The blood is going to pool, which forms a hematoma, which then causes an obstruction, okay? So it constitutes 25% of all heart attacks in women. And all heart attacks in women under 60. The cause, as I mentioned, is largely iatrogenic, so it's unknown, but has been linked to multiparity due to the heightened hormonal milieu and some connective tissue disorders such as Marfan's and Ehlers-Danlos. So SCAD is a very challenging diagnosis, even when these patients do present with STEMI-positive ECGs and they do get up to the cath lab. There's 3 types of artery dissection. Is only type 3 it's the least able to be diagnosed with radiotransluminescence in angiography. But as it says here by Dr. Esther Soo-Young Kim, SCAD is a challenging diagnosis for a number of reasons. While its appearance is very obvious on some coronary angiograms, on others it can mimic plaque or mild coronary artery disease caused by atherosclerosis. So this is our critical stenotic framework. This is the framework that we all currently live and work in. This is the framework that drives me crazy. This is the framework that gives me chest pain. So it's great. It works sometimes. It does not work for women, and let me tell you why. So we have, you're all Fanshawe grads, so you're all very aware of the atypical symptoms of cardiac ischemia and infarction in women. Give me a couple of them. Sorry?
Back pain?
Yep.
Fatigue?
Yep.
Nausea?
Yep. Excellent. Okay, so these are our more sort of Hollywood ones that now, luckily, due to the Heart and Stroke campaign, we're moving away from. So we have our chest pain, pallor, shortness of breath, diaphoresis. We do our ECG, explodes, STEMI. So we either do a cath lab activation, but definitely troponin testing, and then some stress testing as well. So the difficulty with this is that all the 3 ACS syndromes that I mentioned are very poorly detected in ECG. The sensitivity rate is extremely small. I didn't present any specific graphs for you today because there's still not a lot of expert consensus on exact levels, but it is absolutely deemed the most ineffective tool to see microcoronary dysfunction, to see cardiac syndrome X, and to see SCAD. Troponin levels as well, we'll get into that in a second. Might as well just go to the next slide now. So this is our more multifactorial approach, okay? This is my dream slide. This is the future model. So at the bottom we have all of our, so we're still considering our critical stenotic approach. It's absolutely important. It saves lives. We're keeping it. But we're also considering what this multifactorial approach is about. So at the bottom tier here, we have all the atypical symptoms, some of which you just described. And also no pain is a big one as well. And unusual fatigue, unfortunately, has an insane predominance as well. So please don't take that one off your radar. And then when we move up the tree here, what do we have? What are all these words? So for purposes of time, we can't go into it too much, but the first box here is the blood serum profile testing. So troponins having just a universal level for troponin elevation is not working for women. There's other biomarkers that hold way more promise for sensitivity for ischemia and infarction. Some of those are hypersensitive C-reactive proteins, interleukin-6, serum amyloid A's, and even, so the differences, like I said, and the specific levels for sex-specific markers are still being established, but there's a lot of promise with 60 nanograms per liter, and CBIN-1 that just came out of the conference yesterday. Handheld cardiac ultrasound, which I showed you at the beginning of this presentation, is another tool that I'm proposing as an emerging adjacent clinical competency to 12 and 15 lead ECGs, because we can detect mechanical changes that aren't yet seen on the ECG. Then we have IVUS and OCT, both very invasive, expensive, high-risk procedures, one using light, IVUS, or ultrasound, one using sound, and optical coherence tomography, which uses infrared light. Then we have SPECT and PET, single photon emission commuted tomography that uses gamma rays, and we have PET that uses positrons, but the golden standard that's proposed by Dr. Noel Berry-Mertz, which is the most sensitive for detection of MCD and cardiac syndrome X, is cardiac MRI. The difficulty with that and the problem with that in our system is, unfortunately, obviously we're exposing people to ionizing radiation, which is never good, which ultrasound does not do, but CMRI is a very expensive test and is reserved for suspected pericarditis, congenital defects, and other abnormalities. So it's not traditionally used in these other settings. So just a quick recap so far. Symptoms, so we have our common CAD ones, coronary artery disease, versus our cardiac syndrome X, myocardial dysfunction, and SCAD ones. The pathology we've learned now, it's plaque lesions extending into the lumen versus constricted vessels, a more diffuse cellulitis type plaque phenotype. Diagnostic procedures I just briefly mentioned. And treatment, you will be surprised maybe to know that is actually mainstay anti-anginals and beta blockers and ACE inhibitors actually work very well for these women. The difficulty is that they're never actually placed on them because it's not recognized as being cardiac in origin. So moving from the stenotic approach to the multifactorial approach, shifting from left to right, we have also shift in risk factors that I really want you to keep at the forefront of your mind in the field. And the only way you can do that is to have this awareness. So we all know the typical sort of criminals: obesity, inactivity, smoking, hypertension, hypercholesteremia, family history for age of 55, prior infarct. Keep all of those, obviously, risk factors that are crucial to the stenotic framework, but please add at least one or two of the multifactorial risk factors as well, even if it doesn't go anywhere, and even if you're just going to report it to the nurse. So one of those, or some of those, are menopause, autoimmune disorders such as rheumatoid arthritis, lupus, cancer. These are emerging areas of investigation: cardiohematology, cardio-oncology. Depression increases your likelihood of MI. Polycystic ovarian syndrome, diabetes mellitus, metabolic syndrome, gestational diabetes. Did you have gestational diabetes? Did you have preeclampsia? How many children have you had? Please keep some of these in mind. So to draw focus, estrogen has a vital role in the maintenance of arterial wall elasticity. Its decrease in conversion to estrone have deleterious effects on endothelial function. Cardiac syndrome X, microcoronary dysfunction, and SCAD are not well detected by traditional screening tools in the critical stenotic framework. There are significant knowledge deficits that exist in cardiovascular care amongst all healthcare providers and patients alike. Our complacency in the stenotic framework is killing women. Women are under-researched, under-diagnosed, under-treated, underrepresented, causing them to be very misunderstood. So this is my brain break slide. We're almost done. So we're going to talk about a very tragic death in EMS. We're going to switch gears a little bit. We're going to talk about the death of the stethoscope. It was killed in cold blood by point-of-care ultrasound. What is POCUS? POCUS is what I think about all day, every day. I think about POCUS when I'm brushing my teeth. I think about POCUS when I'm parallel parking my car. I think about POCUS when I'm walking the dog. All day long, it's POCUS, POCUS, POCUS. So it's the most beautiful word I've ever heard, but it stands for point-of-care ultrasound. There are many, many uses of ultrasound. But in particular, it has the potential to detect segments of the left ventricle that are moving too slowly, too quickly, or not at all. So we have the potential to see ischemia and infarction mechanically before it shows electrically and before we have long time delays to wait for blood work. So point-of-care ultrasounds, the democratization of anatomical image. Please follow EMS POCUS. Differing from radiologic ultrasound, POCUS aims to answer a predetermined question with a yes or no answer. For example, is the cause of my patient's acute dyspnea the result of a pericardial effusion? Yes, no. How would I do a scan? Find out. It's an adjunct to the physical exam, does not replace our standards of care at all. It is the cherry on top of the cake of what we already do. So it does not replace or deny any patients any right to have ALS and BLS patient care standards. The echocardiography literature so far suggests that some experts report an 80 to 90% sensitivity for subendocardial ischemia and infarction, like cardiac syndrome X, like coronary or microcoronary dysfunction, but not for SCAD. But the WISE and the Mayo Clinic registry tend to disagree. They say it's probably, we can only see 1/3 of that, but I'm absolutely happy catching that 30% on the pre-hospital side of the fence. So there's many different types of POCUS devices, many different types of ultrasound devices that are becoming more and more and more portable. On the top left here, you have the different types of probe. We have a linear phased and curved, linear phased and curved array. Mine is obviously my favorite is obviously the phased array, as that's the cardiac probe. In the middle here, we have the, in the middle here, we have the butterfly that's not available in Canada yet. But that is actually one probe for the entire body. And then next to the butterfly, we have the GE Healthcare's V-Scan. It weighs only 390 grams, smaller than a sandwich I'd eat for lunch, extremely portable. But POCUS is being used in other resource-limited environments as well. At the bottom right, you'll see a Rwandan medical student doing a fast exam in Kigali, Rwanda. So we know the blood supply, more or less, the big epicardial arteries, right, that supply all the tissues of the myocardium. So this is myocardial ischemia and infarction via an electrical lens. This is myocardial ischemia and infarction via a mechanical lens. So the American Society of Echo is very excited about propagating ultrasound with non-traditional users. They're very hesitant about it because times and optimal modes and methods of training have not been established, but they're definitely advocating for it. And in spirit of that advocacy, they've shortened the 17 segment understanding of myocardial perfusion into a 3-segment understanding of myocardial perfusion into anterior, lateral, and inferior segments. So as I said before, these are just, this is my work, these are theoretical projections for cardiac POCUS, where there'd be no time delay. So I'm proposing it as an emergent adjacent clinical competency, and with enough time to research, because it's already being approved by case reports all across the states, and especially in Kingston, out of the Cardiovascular Imaging Network, that it's actually being used as a bypass to cath. So before waiting for that second serial trope, they're getting emerge physicians, they're getting internal resident students to come in, do cardiac POCUS, see a regional wall motion abnormality, and then chat with the interventional cardiologist about it and get those patients to cath lab earlier. So these are some of my POCUS projects. I don't have a life anymore, and I'm totally happy with that. The most exciting one was the hybrid POCUS Echo Lab, provision for remote emergency streaming cardiac ultrasound POCUS. So that was actually proposed for the Innovation Challenge at the last conference of the ASC. So I'm not sure if we made it to semifinals yet because we don't have the results. But other POCUS projects are literature review. I'm actually looking for reviewers if anyone wants to sit down and read 5,000 journal articles with me. And we're also hoping to bring it as a feasibility study in land ambulances and maybe for paramedic students. So this is a just very quick video for generational eye ultrasound that illustrates the live telestreaming technology. I don't know why this is going first, sorry. There we go. Go back. Yeah, there we go.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated teleultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated teleultrasound collaborative platform. Philips Lumify. Integrated teleultrasound powered by React's collaborative platform. Innovation and you, Philips.
And that concludes my presentation. Questions. Sure. One over here in front.
Hi, Isabel, PCP student. So I found a lot of that super interesting, the microcoronary dysfunction. I've never heard of that before, and I've had so many patients that kind of fit that description. It's really fascinating to be more informed about that. But my question is more about the doctors misdiagnosing. So I know in medicine in general, it's really well documented that male doctors tend to discredit female symptoms and what they're experiencing. And that is there any research regarding whether female doctors diagnose female patients more accurately?
Not that I know of. Maybe that's an area of research interest, if it interests you, that you could do, because it's definitely needed. But none that I know of. It's basically just been physicians grouped in general as their misdiagnosis. But I do also have an appreciation for how difficult the diagnosis can be when all of the tools that we're using to actually screen are ineffective. So as frustrating as it is to work in this system, I also appreciate that it is very difficult and highly nuanced. Are there any other questions?
Hi, Mike, PCP student. Just a couple questions. I'm just curious, because that video is really, really cool, and it's awesome to see how, I never realized how portable that can be. So it's definitely something logistically that we could definitely carry around with us. How much does one of those units cost?
Yeah, so that's a good question. I don't know. Yeah, and I'm not sort of the tech lead in the team, so I don't deal with any of that kind of stuff. But I know that the, for the iPad and the telestream, I have no idea how much that costs, but I do know that the V-Scan by GE Healthcare, that's widely being propagated by cardiologists and internal medicine residents, I'm having a stroke, is about $8,000. That's a small one, but not the one you're talking about. I don't know how much that one is.
And then, do you have any knowledge on how, I'm not sure how familiar you are with any literature or knowledge or whatever on how long it would take to potentially train people with zero experience?
That, my friend, is the $1 million question. So that's what we're working on right now. So we're writing proposals, working closely with cardiologists, especially at Queen's from the sync department. And at the end of this month, we'll have a better idea of even a timeline to sit down and get some really rough, malleable documents together. Because as exciting as it is and as easy as POCUS can look, and it's not easy, especially not cardiac POCUS. Lung ultrasound is easier. It's much easier to detect A lines and B lines, and see signs of congestive heart failure and see fluid overload than it is to do highly technical wall motion abnormality assessments. So the stuff that I'm hoping to do is unfortunately the most technically demanding side of the fence. So what it will start with, which is some of the proposals I'm writing now, are very basic image acquisition stuff. So it'll be a little bit similar to the implementation of 12 leads. Initially it was all about acquisition, and then it was about interpretation. So the phases I'm writing right now are triphasic models. The first one is, can a paramedic get a clean image on one plane? Then and how long did it take? And what is the quality of those images? And what percentage of those images can be considered high-yield diagnostic images? Then phase 2 will be, can a paramedic obtain a diagnostic quality image on all 4 planes? And phase 3 will be like, can a paramedic adequately assess left ventricular function? Can they rate it into categories of abnormal, normal, moderately decreased? So it's going to build very, very, very slowly. But the initial literature that's being suggested right now by Dr. Marjorie, who is my mentor out of Queen's, with his resident students, is that 1 month of time. They did a trial with 1 month, had two arms, a technology arm and a conventional traditional arm, and they found a very high rate of false positive diagnoses, because we think the technology is small. Oh, this is on my iPhone, this is going to be easy, but that's actually pretty terrifying to cardiologists.
Great, thank you.
I think it was a great presentation. My name is Jerry Segan, I'm a paramedic. Do you have any books that you would recommend reading in regards to POCUS? More specifically pre-hospital, or, not specifically cardiac necessarily, but just POCUS?
Yes, I do actually, and I've been asking the same questions. I have a handbook right now in my purse that I'll show you. And there's a few others that I can give you names to. Yeah, I don't have them on the top of my head, but I'd be really happy to connect with you and share those. There's also the ultrasound podcast that is on YouTube. That is a pretty phenomenal resource that have been places that other experts and cardiologists have directed to me. And then there's also the POCUS Journal out of Kingston, and that's an app as well. And just so everybody knows, the ECG from the very first slide, that was a very subtle ST change. That was actually a 90% blockage of the left anterior descending artery, and it was only evidenced by POCUS.
So I've had the pleasure